Northern Ireland Rare Disease Partnership is a not-for-profit registered charity. It's a unique partnership of people living with rare disease, and it consists of 30 representatives from 30 plus different condition organisations. There's over 6,000 rare diseases recognised worldwide, with more being defined all the time with a better diagnosis. The aim of the partnership is to work constructively to advocate, educate and innovate on rare conditions, and our motto is Stronger Together. What do we expect? I'll start off with a quote from the OFM-DFM Quality, Good Relations and Human Rights Strategy Action Plan from January 2008 is, our health and social care services will be characterised by openness, integrity and fair treatment for all. And we expect, within the terms of this inquiry, that we should have quality of care, good communications and information and participation, and we will give evidence on that. We're talking about quality with a focus on the right to respect for dignity, responsiveness to need, including that for the most vulnerable and marginalised members of society, and the provision of support for appropriately skilled staff. Information is vital. The provision of appropriate information is just essential for anybody going into an emergency department, and it's exchange of information as well. It's not just a one-way street. And it's participation, the participation of the patients and their families, active participation, because they are the experts on their own condition. They're dealing with it 24/7 and they have the first-hand knowledge. The problems that we have looked at are the systemic issues, communications, mental capacity, logistics, and staff training and morale. And we also want to talk about emergency care and rare disease, and some with case histories for that, and complaints and transparency. Case studies, we hope, will illustrate increased possibility of unscheduled care, the negative impact on the quality of care, good communications and information are essential, and the need for greater participation of patients and carers, especially during emergency care. We also have put forward some solutions, including the implementation of the Northern Ireland Rare Disease Plan, the changing of the culture, establishment of care coordinators, patient healthcare passports, personal and public involvement, the red flag on electronic care records, a rare disease information hub, and targeting inequalities. That's me.
Okay.
So, if you want to start.
Do you need to ask any questions? Or?
Yeah, no. Have you finished, Francis?
That's it,
yes, that's it. Sorry, I wasn't just quite sure if you.
Sorry.
No, that's quite all right. If I could ask a couple of questions to start with, and we've had evidence from individuals with rare diseases before us, and it's clear that some good ideas aren't always rolled out effectively in practice. So I think we were familiar, for example, with the patient passport, but that on some occasions it's clearly not working on the ground when people arrive in emergency departments. And I suppose what I'd like to ask to start with is to tell us what you think are the key issues and how you would deal with them. And I'm thinking here of not just in emergency department, but also in all the other ancillary services that have an impact on the emergency department. So I'm thinking as well about out-of-hours doctor services, minor injury units, the coordination of community care services with emergency department services. So to use the language of the healthcare system, the kind of pathway in terms of who gets into the emergency department and where you should be treated, and treating people in the right place at the right time, etc. So looking at all of that, what do you see are the key issues in terms of treating people with rare diseases, and what should and could trusts and others do more effectively.
I hope you don't mind if I just read this right.
Yes, no, that's fine.
Right. There is absolutely no way of knowing the number of patients who are admitted to emergency departments in Northern Ireland unnecessarily, and where there will be confusion, delays and risk to safety in those departments due to a rare disease not having been diagnosed, misdiagnosed, or simply because a diagnosed rare disease is not well understood either by those delivering care in the community or by emergency department staff. HELP 2020's report for Forgotten Conditions, Misdiagnosed and Unsupported, How Patients Are Being Let Down, criticises the overwhelming focus on treating a handful of major illnesses to the detriment of developing systems for diagnosing and treating the increasing number of rare diseases. As a result, thousands of people suffer for years with misdiagnosis and inadequate treatment, costing the system a fortune and nugatory expenditure of scarce resources. Our experience shows that while some people with rare disease do receive good care, very many care professionals at all levels of the HSE system are largely unaware of the signs, symptoms or behaviours which can provide proper diagnosis of the manifestations of rare diseases. The Patient Client Council's report, Experience Diagnosis, which was published in 2012 and which NIRDP collaborated in bringing about, reflects the reality that even though there are over 6,000 different rare diseases, each with its own unique characteristics, those affected face common problems in getting the care, support and treatment they need. 29% of patients wait between 1 and 5 years for a correct diagnosis, and over 20% wait over 5 years. 34% of patients are misdiagnosed, 20% of whom received inappropriate treatment as a result. Patients have to attend multiple appointments with different health professionals to obtain a diagnosis, and it is frequently a battle to do so. 57% of people caring for a person with a rare disease do so for more than 20 hours a day. We're going into this. Over 40% of patients describe their experience of the health and social care services in Northern Ireland as poor or very poor, and nearly a quarter described it as average. Only a third of patients describe their experience as good, very good or excellent. Patients also reported feeling ignored by doctors and that there is a lack of information and support for rare disease patients. So what actually happens is that without the diagnosis, there's nothing there in the community. There's no support, there's no financial support, there's no proper treatment, there's no management of rare disease. Many rare diseases can be managed even when they can't be cured. Mine actually, Wilson's disease, which I have been diagnosed with, can be treated successfully. Without treatment, it is usually fatal. So there is not, without that support or without the diagnosis, it increases the risk of unscheduled care. Then when people with rare diseases who do arrive in the casualty department, they are faced with a very, very busy staff who aren't going to have time to sort problems out. They could be left, the delays could put them at risk. They could be given treatment which doesn't suit their illness. There are many, many issues, and I think I should quote a case study that we have. It's actually on progressive supranuclear palsy, where one gentleman who had progressive supranuclear palsy was misdiagnosed as having dementia and Parkinson's disease, and he was then prescribed Matapar. Now, not only was he subject to the unnecessary side effects of the Matapar, but Matapar was not designed for progressive supranuclear palsy, and it's not safe. So a lot of people who have rare diseases, and according to these reports and the Rare Disease UK reports as well, who are not being diagnosed or who are not receiving the proper care because nobody knows what that proper care is, are arriving more often in casualty departments, and that will put an extra stress on on those people. And I think this report will detail all that and give you the references to any documents you might need, which are proof of that.
Mm-hmm.
So I
think further to your question, Les, you were talking about general pathways associated with unscheduled care, and it seems that not only do we need the Northern Ireland Rare Disease Plan to be implemented, and that will help to produce guidelines for people with rare disease and a range of things, but we need to actually keep people out of A&E in the first place to stop them getting that far. And we strongly believe that what we need to do is to value the skills and experience of our GPs, to build on that, look at the community-based staff, the people in all the clinics, the out-of-hours service, to build up the minor injuries units, and nothing to do with rare disease, but it was a matter of some concern for me recently when one of my children hurt herself, and I didn't know whether she needed emergency care or not. I assumed she didn't. And I thought, well, that's okay, I'll go to the minor injuries unit, only to discover that actually the minor injuries unit was in the Royal A&E. Well, I don't want to go there. I don't think she needs to be in A&E. And she didn't, and we worked something out. But had she been slightly more ill, we would have ended up in A&E for what was essentially just a badly sprained ankle. Nowhere near the right place to be. But there wasn't a middle stage. For our area, there wasn't a minor injuries unit, and in many other areas the minor injuries unit closes at 5 o'clock, or the radiographer stops work at 5 o'clock, and so you have to go to an A&E anyway. So there are a number of issues there, so that if the community-based services and the skills of the community-based staff were valued appropriately and resourced accordingly, then, for instance, if we had minor injuries all the time, rather, that would prevent many visits to A&E for what are neither accidents nor emergencies. A key thing also for people with rare disease, we believe, is the need for care coordinators. These would be individuals who may be specialist nurses or may have other health and clinical skills, but they would coordinate the community-based care and be contacted as soon as possible following an unscheduled admission, because obviously people will have unscheduled admissions. But in an ideal world, those care coordinators, or indeed GPs, if we're recognising the skills and experience and valuing that with community-based people, would be able to fast-track people into wards, because they know the people, they can assess them. Nobody wants to be sitting in A&E for 26 hours waiting on a bed somewhere. That's obviously a distressing, humiliating experience. And if there were, we're looking at ways of preventing that from happening. So if you can keep people out of A&E in the first place, and if they do have to go to hospital, have ways that people who already know them, who already know their particular situation, can fast-track them or directly admit them to the most appropriate wards, rather than having them hanging around A&E for hours to be assessed by somebody, again, who doesn't know them as well. Do you want...
Let me ask my second question, because I think you're moving into the territory of it already, which is your rare disease plan. Tell us how much traction it's got in terms of discussions with department boards or trusts, or where that's at, and how you found the response to the rare disease plan. But secondly, I think you're probably already moving into this territory, which is, what are the key points in the plan, if you like, that are particular and specific to emergency department and the other ancillary services that I was talking about earlier?
Well, in general, because, as Francis has detailed, the partnership is a fairly unique method of working. It's not simply patients and charity representations. On our board of directors, we have patients, we have charity representatives, we have representatives from the pharmaceutical companies, we have academics, we have senior clinicians, we have advocacy workers within the hospitals. So we have people working in many parts of the health service. Many of those people, probably about half our board at some stage or other, are on the Northern Ireland Rare Disease Stakeholder Group, which is run by the Department of Health here. Some of our members were involved in the development of the UK plan. for rare disease, which was launched last year. And the 2 or 3 of our members have representation on the UK Rare Disease Stakeholder Forum. I'm not one of those people, so I can't remember the names exactly of the various UK bodies. But there are There are 2 strategic UK bodies. One primarily for patients, one less for patients, but we have advocated for and got Northern Ireland representation on that group. And then there's a rare disease advisory group, and Christine sits on that advisory group as a lay voice. So we have quite a lot of representation at a UK level and appropriate representation more locally. We also work very closely with the rare disease charities in the Republic. The UK Rare Disease Plan was launched, and we're now in the process of anticipating the launch of the Northern Ireland Implementation Plan, which is due at the end of this month. And that's about how the UK plan actually happens here.
Sorry, has the Department of Northern Ireland signed up to a Northern Ireland plan as part of the UK-wide? Or?
Yes,
yeah.
they have. The department have released a statement of intent to produce an implementation plan, and they've signed up to the UK Rare Disease Plan. And the implementation plan is to be launched at the end of this month. I say members of the partnership have been involved in the creation of the implementation plan, and also in the UK plan as a whole.
And what is in the plan that's specific to, if you like, our inquiry in terms of emergency department and the ancillary services? Are there specific things in that?
The plan I haven't seen yet. We're aware of the broad themes of the strategy, and we think all of those things are relevant. The vision is that no one is left behind. One of the themes is empowering those affected by rare disease, so recognising that the real experts are the patients and families themselves, and that's vital for emergency care. We know lots of examples where people have gone to emergency care as a patient themselves or with their loved one, and have been, because of their experience, they live 24/7 with these conditions. They know how these conditions affect their loved ones or themselves. And they go to emergency care and they say, this is what you need to do. This is what this individual needs. And that's not heard. And so the sick person gets assessed and reassessed, and they do some more tests. And in the meantime, the family are saying, yeah, we know what's wrong. This is what they need. And there are long delays while hoops are jumped through before they actually get what it was the family knew they needed all along. And during all that time, the individual's getting sicker and sicker. And there are ways in which that situation can be better managed by recognising the expertise of the families. Another thing which would be enormously helpful for emergency care staff is an information hub. What we would like, and I was listening to some conversations earlier today about the development of the Northern Ireland Electronic Care Record, and how that the rollout of that has been enormously successful, and they're very pleased with how that's been working. But they're very clear about what needs to happen next with it. And there are numbers of things, patient access, patient actually owning the information and able to annotate it. And putting alerts on it. And one of our suggestions would be that there's some sort of a red flag. This individual has this particular rare condition or these particular rare conditions, and these are particular issues that you need to consider in the emergency room. Now, if there were some way of linking that to an information hub that said, to take my mother's example, this woman has progressive supranuclear palsy, comes up as a red flag, but the guy in a Skilling hospital still hasn't heard of progressive supranuclear palsy, and that there's some link to information immediately on what progressive supranuclear palsy is, and what particular issues might be presented there. Other things in the plan are about identifying, preventing rare disease, diagnosis and early intervention. Carol's already talked about coordination of care. I talked about the importance of research, and we could talk about that for hours, but will not, unless you particularly want us to. And also particularly working very closely with the Republic, and obviously there are issues there. One of our case studies that we have is about an individual who brought her child to one of the A&Es in Belfast, looked at the length of the queue, turned round, put the child back in the car and drove to Dublin. There are issues there. I'm not sure if I've answered your question or not.
No, I think you have, and I'm going to pass you to Marion.
Can I just add a little bit to that?
I want my colleagues to have a chance to ask questions, and what I'll do is give you a chance at the end to round up. I'm just very conscious of, I've got two colleagues, neither of whom have asked a question yet, so if I may, I'll get them to ask a question, but I'll give you an opportunity at the end to make some concluding remarks, if that's okay.
I'm wondering, we've had a witness who talked about having a patient passport, and her experience of it was that while she brought it and it had all the information, it really didn't guide staff in the A&E department who seemed to really not take any cognizance of the information that was on the patient passport. How do you find the patient passport working? Would that experience be typical, or would that be very rare that the information isn't used?
Well, I think, judging by what the feedback from other patients too, is that it actually works. We have one gentleman who actually is he's a big advocate for it. He says it really does help. And I know in the group of the cohort who are being tested with it, that they seem to like it. Now, this first draft, if you call it that, of the patient passport is actually, it's made for people who cannot communicate at all very well, or that is what it is planned for. So it is limited in that, but that it's appropriate that that would happen, because the patient passport is for helping people to communicate. I think over time it will be developed, but I think that, to include all long-term conditions, if it could be developed, it would help me a great deal. I know I haven't been in casualty for a while, but I know the last time that I was in, I panicked because of so many things wrong, and I was babbling. I know I was babbling, at this and of that and the other, and the doctor was trying to ask me questions. But, I eventually realised I'm here supposed to be the one who knows about all my illnesses, but I'm confusing this doctor. And I think if he had just been able to read a page that said that, rather than me not well, under probably stress from being in the casualty in the first place, did receive good care in the casualty, but he didn't need me babbling on of this and that and the other, and this affects that result and other affects another, and maybe red flags and things to watch for. He really didn't need a patient who wasn't well at the time trying to tell him that, and I think it would have been better written down. I think it needs developed, but I think it has started at the proper place, aiming, targeting people who cannot communicate very well at all. I think we do need it. I think we need a change in culture. That's probably what's wrong. That there can't be too much information, or people won't read it, staff won't read it. But we need a change in culture throughout the system to realise that these are important and the patient voice is important.
Mm-hmm. I think there are a number of issues there. One of them is the fact that the patient voice and the patient's family as experts isn't always recognised. So, years ago, whenever I was going to casualty with my mother on a regular basis, because her condition meant that she fell and injured herself on a regular basis, and I would take along a photocopied sheet that I'd printed from the internet about going into hospital with her condition. And everybody go, yeah, and that's great. And throw it down somewhere. Or, I don't have time to read that. And one of the things that has happened recently is that a number of different formats are called passports. So, whenever we talk about, whenever the term patient passport is used, it might actually mean different things. We worked with the Royal College of General Practitioners on this one, and this is the one that Carol's talking about. It's what I need you to know, my healthcare passport. And I can leave that with you if that's not the one that you're familiar with. This, as you can see, it's a handheld record. And one of the things that I liked about this is that it's got a Health and Social Care logo on it. The Health and Social Care Board and the PHA were involved in the design of it. They paid for it. Something with the Health and Social Care logo on it and an RCGP logo on it carries significantly more weight than my printed off sheet from the internet, because what does that mean to emergency care staff? In many ways that's very simple and very straightforward, but as Carol says, it's starting in exactly the right place. And one of the very good things about this is that whenever the RCGP in Northern Ireland decided that they wanted to develop something, their idea was that they were going to develop an end-of-life passport. And then they started working with people, patients, communities, and realised that that wasn't particularly what we wanted. It's now much more than that. It focuses on the information and coordination needs of those affected by progressive conditions and their carers. So it's identifying the needs of people with progressive conditions long before it becomes an end-of-life situation. It's about the totality of care. And this almost works hand in hand with something like the electronic care record. The electronic care record will tell health professionals what's wrong with you. This will tell them what matters to you. So this will tell them what you're called. You know, you might be Mrs. Elizabeth Brown, but to everybody in the street you're Betty, because you like to be called Betty. Well, this will tell them that it's Betty. Betty has a dog called Fred. You know, it will give them information that Betty is unable to communicate herself, but which will make her stay in emergency care or in all her contacts with health and social care professionals, it will personalise that if they take it on board. It will, it has information about medications. You know, you could give that to an ambulance man, and they would be in a position to know some information about you before they can access the healthcare record. But for the majority of time, that's about saying, this is what matters to me. These are the key people. My care coordinator, if you had one, is in there. It really does help achieve the objective of making life better, which is one of the departmental proposals, and support, engagement and empowerment for people.
Can I just ask one other question? You said in the paper you submitted about the absence of any registers for rare diseases, and you've also noted that there's no HD register in Northern Ireland. Disease. I mean, do you have any idea why there's a resistance to creating registers?
Well, I'll try and answer that. And it'll actually be the answer to the question that I needed earlier, or I was going to talk about earlier. This is the first implementation plan. There's been nothing there before for us, and that's why it's so important. And that's why you'll find that people with rare diseases, or who have met others with rare diseases or worked with people with rare diseases, are so passionate about it, because we have been so isolated. And when you realise you can't maybe find somebody else who has a rare disease the same as yours, but you can find people who have experienced common problems. Now, to get really to your question, I think the problem is that rare diseases have been forgotten about. And nobody's thought, well, oh, there's only a few of here and there's only a few there. And don't bother with the registries. Don't bother. They're going to cost money. Why would you bother with this? These are just rare diseases. You know, few in number. But cumulatively, they're not rare. And they will cost money. And they will take time. And for in the A&E departments, when people have unscheduled care because they're not being properly monitored or looked after at home in the community. The registries are very, very important because there's going to, as Health 2020 has pointed out, there's a lot of people with rare diseases haven't been diagnosed even. So they need to start getting the diagnosis improved, and then they need to get registries to find out where, you know, the demographics in Northern Ireland are for all these rare diseases that aren't now missing because they haven't been diagnosed. And that will mean that they need those because of planning commission for the delivery of care. But at the minute, there's been very, very little there. So we're very excited about the new implementation plan. This is the first of its kind here. And that really answers the question that it was going to talk about earlier, that you can't say there's any specific thing in the rare disease plan, the new rare disease plan, that will help to do with A&E, because it all will affect A&E patients and the numbers that are going in, because there's nothing been there before.
Thank you very much. Thank you.
Paul.
Just one very short question. Would you care to comment, perhaps one of you, because time is passing, on any experience you have or view you have about the PCC and whether or not you found them a constructive partner in your work or not?
For the development of the Rare Disease Partnership, the PCC were incredibly helpful. They helped facilitate the formation of the charity and did some work with us, as Carol has mentioned, on the original survey, the experience of diagnosis. We haven't had an ongoing relationship with them. Now we're more likely to work with the Public Health Agency or the Health and Social Care Board. They have supported us with our more recent work. But when we were in the process of establishing the PCC, were very helpful.
Thank you very much, Fiona.
Okay. Francis, Fiona, Carol, thank you very much. And Carol, I'm sorry I had to cut you short. I'm glad you've got the comments that you wanted in. We've said to everyone who's given evidence to us, if there's any additional information you want to give us, that would be very useful. And I think you've said you've brought stuff along. So before you leave, make sure we have that, because that will be very helpful indeed. But it's really an opportunity to see if you want to make any final comments, either anything you think you haven't covered, or to augment anything that you have said just before we finish today. So any final comments from any one of the three of you?
Well, I'd just like to make one comment about with some rare conditions, and I'm coming from a family, a disabled child point of view, in that if these conditions are not recognised or understood, quite often there are judgments made by emergency staff, and we've cited the examples in this. Things like if there's a very rare chromosome deletion and there's associated challenging behaviour, that one parent heard her child being described as spoilt and badly behaved on the phone to the ward because the child had to be admitted. And people who bring their child or their loved one into an emergency department are already distressed.
Yeah.
And to hear comments like this made really, and it's really just because of a lack of knowledge and communication, that adds to their distress. You know, and I think there just needs to be more in staff training. And I think that also would help staff morale as well. That if there's adequate training at the very start and understanding that there are conditions they're going to come across that they do not know, they're not expected to know about them, but they're expected to listen to people. and take that on board.
Okay, thank you. That's been
Thank you.
really helpful, and it's also been very useful to have one or two people who've appeared before us actually with rare diseases who've told us firsthand about their experience. So the other case studies and the other material you have will be really helpful. So thank you very much.
Thank you.
Thank you.